The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. I hope everybody is having a great middle of their Thursday so far. We're almost to the weekend, almost on the Memorial Day weekend. We've almost made it there. Before we can get started, I just have a couple things that I have to, well, not a couple things I have to go over, but a couple things that we would like to share. If you have any questions, just like any other presentation we have done with this webinar series, go ahead and put them in the questions tab, and we will go over all of those at the end. As you will see, we do have the handout as well in there. Hopefully it works. Last time we did a PDF, it was a little funky. So if that doesn't work, we can figure out something else. And we will also be putting a recording on Leading Age Michigan website on our COVID page. We always have the recordings of all the Safe and Calm webinar series there. So if you have missed any, or if you want to check that out, feel free to go there and you'll find all the recordings for the previous webinars, and this one will probably be posted either today or tomorrow would be my guess. Now that we've gotten that out of the way, we would like to say thank you to our valued business partner, PointClickCare, for being part of our Safe and Calm webinar series here today. With PointClickCare, you will connect, communicate, and access the insights, partners, and tools you are helping solve with real challenges for senior care providers of all sizes and complexity. They can help you explore everything their integrated platform has to offer with solutions designed for skilled nursing, senior living, home health, care delivery, care coordination, business intelligence, and financial performance, just to name a few. Our presenter today will be Pam Campbell, the Marketing Insights Specialist, and with PointClickCare, obviously. And now I'll turn it over to her. Thank you.
Wonderful. Thank you so much for that introduction. And I'd like to welcome you all today to the COVID-19 series in the Safe and Calm webinar series. So today we're going to talk about a COVID-19 update. We do have some new things that CMS and the CDC have released that we'll go over and talk about. And also we'll talk about some lessons learned so far. Okay, so the things we'll talk about today is some key strategies to prepare your staff for the infection control focus surveys. We do know that those are what are being conducted at this time. We'll talk about the return to work and the new reporting criteria for COVID. We'll explain strategies to survive the stress of a pandemic, and at this point in time, that's one of my biggest concerns for you, is just the ongoing day-to-day stress of dealing with COVID-19, whether or not you have cases in your building. And then we'll talk about some lessons learned so far and what we do moving forward as we deal with COVID. So just going back just a couple months ago, March 7th, 2020, there were a total of 213 known cases in the United States. Fast forward just a month, and we had hundreds of thousands of cases in the United States. Now we look at just a couple days ago and what it looks like now. Well over 1.5 million cases, known cases in the United States, and those are just ones that have actually been tested, right? So we all suspect that there's probably more than that. Throughout the slide deck, you'll notice at the bottom of the pages there will be a lot of different resource links for your use ongoing. When we convert it to PDF, usually the links don't work if you click on it in the actual electronic document. So I always put the entire link there so you can copy paste it or type it into your URL address bar if you want to go to any of the different documents and web pages that I referenced throughout the presentation. As we know, our elderly are the ones that have been most impacted by COVID. We know that they are immunocompromised, that they have multiple comorbidities, which make them at a higher risk for the different symptoms and diseases that go along with COVID, especially those respiratory diseases. We have a lot of people with heart disease, clotting disorders that are predominantly higher with some of the more serious cases, and diabetes, and just those multiple comorbidities that make them at a much higher risk than other people. It's not that no other age group can contract COVID-19, but we do know that our elderly population is much more impacted by this disease than anyone else. Now, these statistics aren't specific to nursing homes. I just want to point that out. This is just a general age group, but we know the age group that we serve is in this 58% group that is illustrated here in this graph. Just looking at the national forecast, and again, I pulled this down on the 19th as well. And this, the national models still are projecting, if you look at the mean data, still projecting 125,000 deaths in the United States due to COVID. Could be more or less, but that's the mean that they're projecting at this point in time. It really is interesting to me how last year, when, well, actually since the beginning of the Impact Act, but the CMS focus on infection control, infection prevention and control, and through the 3 phases of the requirements of participation, each phase increased the requirements for infection control measures. And at the end, phase 3 was the infection preventionist, who was that individual who has specialized training and who is going to really guide and govern the infection prevention and control practices within your facility. Talk about a trial by fire. Wow, welcome. But it's such a good thing that that person is available to you, and that they did have that additional surveillance and infection prevention and control training. And I'm hopeful that you all are utilizing that person to their full extent as you deal with this pandemic. So in addition to the infection preventionist, one of the things that CMS changed is their survey protocol in response to the COVID pandemic. And that is having an infection control focus on their surveys. And so in addition to your normal regulatory compliance, you always need to be prepared for a thorough scrutiny and expected competence in the following areas. And that's complete state or federal rules for infection control, for your emergency preparedness, which will include, but certainly not be limited to, your COVID-19 strategic plan, information regarding PPE or that personal protective equipment, your infection preventionist leadership, infection control staff competencies, and the infection preventionist role and responsibilities. And expect for that infection preventionist to spend a great deal of time with the surveyors when they come in for your infection control focus survey. That person needs to be well versed in your disaster preparedness policies. They need to be well versed in where the facility's at related to cases. They should be knowledgeable about what is going on within the community or the region in relation to COVID, whether or not you have COVID cases. And so that person really will be your front line with this survey process. In addition to that, they will also interview your staff to make sure that they too understand their role in protecting the residents, not only with prevention, but control of infections and certainly COVID. So it's important that you're prepared for that. They don't last as long typically as a normal certification survey would, licensure and certification, but they certainly are intensive and appropriate for what everyone is going through right now. So as you prepare for that, and as you just prepare your facility to be able to safely operate in the age of COVID, you need to be sure that you've evaluated the level of staff competency in regards to hand washing, alcohol-based sanitizer policy. They should know what your policy is and how they would comply within that policy. Proper disinfection techniques. This COVID is not just a nursing concern, it is a facility-wide concern. So be sure that your maintenance department, your housekeeping department, your laundry are well versed in proper disinfection techniques and safe handling of contaminated laundry. Isolation procedures. Your staff should know what isolation procedures there are and what they do based on what level of isolation a resident might be in. Donning and doffing PPE is incredibly important, and we've had some facilities that will show a video. This is, this is how you do it. But I believe, I'm a hands-on learner, I'm a visual learner, hands-on learner. And so I believe that giving them a gown and gloves and a mask and a face shield and all of those things that they would need in the event that you did have COVID cases in your facility, that they know how to not only put it on safely when there is no contaminant to deal with at that point in time, or no known contaminant, but even more so how to remove it safely, how to remove things without contaminating themselves in the process, or contaminating an area or other pieces of equipment, or so it's very, very important that you spend a good amount of time on not only putting on protective equipment, which of course is very important, but even more important is removing it safely so as not to contaminate themselves or others or other pieces of equipment. Your staff should know, and again, all staff should understand the symptoms of COVID in themselves and others. So if they start running a low-grade temp, they start having a bit of a cough, they have some GI distress that they didn't have before. GI is one of those things that has been added to the list. The list has grown from 3 different symptoms to probably 10 or more. Based on the data, as we have had more cases and been able to gather information on each patient, then we start to see additional symptoms that are common with COVID as well. And so making sure that not only in themselves, but they may recognize it in someone else. So it's very important that we really have a team mentality to be able to protect not only ourselves and our families, but also our residents. As I mentioned, being able to properly handle laundry and food, your healthcare acquired infection facility policy, and social distancing. And I think as we look into the future, probably life as we knew it before may not go back the way it was. We may always be a little more aware of social distancing. We may always be more prone in a highly populated area to perhaps put on a mask. The thing about masks that I want to be sure, I want to talk just really quickly about masks. There's three different levels of masks. You have your masks that are just a cloth face covering. That might be a bandana or a scarf or something like that. That is not considered PPE. Okay, it's just a cloth face covering that they feel help to contain any. It helps to keep you from having droplet spray when you talk, you cough, you sneeze, all of those things. It helps to contain those droplets. Not necessarily keeps everything in, certainly, but that's your cloth face covering, and that is not PPE. Then you have your face mask, which is like a surgical mask. The ones with either the ties on them, or they may loop behind your ears with elastic, and those are considered PPE, but they are for surgical or medical procedures where you might be subject to spray, like in a surgical or medical procedure. There may be spray from that procedure, and that is to protect you from getting those droplets and particles in your mouth. And so the other thing to keep in mind, and that's what most people are wearing today, is face masks that you'll see in public and in facilities. That's what most are wearing. And those have benefit, but they certainly do not prevent all of the pathogens from either coming into the mask or going out of the mask. And they say that the biggest benefit to wearing mask is for source control, meaning you're keeping your droplets, your spray, your bugs from going through the mask. So it's actually protecting other people, not necessarily protecting you. And if everybody does that, then that is like a double barrier, and really is, and there's some discussion on effectiveness, but the double barrier really does seem to have a good impact on your likelihood of contracting other diseases. So as always with all of these things, this is the information as it is available today. It changes so much. It's still an evolving thing, even though it's, you know, a few months old. We're still learning new things about COVID and how it's transmitted and the spread, and how to protect ourselves and our families. So just understanding this process and understanding the different types of masks. And then of course there's that final type, and that is your actual respirator. A respirator is PPE. It filters out the majority of particles and pathogens. It fits tightly around your face, and it's typically fit to a person. So it is something that is really well fitting, form fitting to your mouth. Now, the one thing I want to talk about, I don't know if any of you have seen the respirators or the masks that have valves in them, kind of like on either side of your mouth. There will be like a round valve. Those are not, they don't feel that those are helpful in keeping out particles. So just keep that in mind. Probably that's not the type that you would be using in a nursing facility anyway. So those are the three kinds, and you'll want to be sure and understand the differences in them. So moving forward, your staff are going to need to be able to recognize signs and symptoms like never before. They're really going to be your front line in identifying anyone who may be symptomatic. And as we all know, early detection and early intervention is the key to preventing the spread of any disease, whether it be COVID or influenza or the common cold, or, you know, GI flu, any of those things. So we knew that it was coming, that infection prevention and control was really starting to be a focus of CMS. But with COVID, that has just, you know, taken it off the charts. So, and then they need to know what to do with that information. So if they suspect, or you have a CNA that takes someone's temperature and it's, you know, 101.4, or you have someone who has a new onset of a cough or GI concerns or that type of thing, they need to know to notify the nurse right away so that appropriate intervention can begin. So ongoing preparedness, I know we are all feeling like and hoping that we have maybe reached the peak and are maybe on the downhill side. I just would like to caution you that the jury is still out on that, and we want to really make sure that um, we stay incredibly vigilant, especially with our population. And we know that we are going to have to open nursing homes up soon. Um, our residents and our families have been, this has been a difficult time for everyone. I was sharing before that my father is actually in a nursing home, and he's never had depression in his entire life. But through this time, with family not being able to visit, now he is struggling with some depression, and he doesn't really want to eat. And, he did well for a couple months, and now it's really, really getting hard. And I think that's pretty common with everyone. That's not to say anything about the great people that take care of him on a daily basis. They're wonderful. Um, and they're caring, and they're doing everything they can to help mitigate the effects of this in isolation, basically, from their family and loved ones. But they're not family. They're family, but they're not. It's not his wife. It's not my mom. It's not me or my brother or any of the grandkids. So it's really been difficult. So um, I just really encourage people, as you continue on with your journey with this pandemic and COVID, that as we start to open things up, as states start to lift restrictions, and local municipalities start to lift different restrictions, and people start kind of going back to some sort of normal, that also increases the risk of COVID. So it's really important that you and your staff understand the elevated risk. Even though we're all so thankful that things are starting to open up again, it also increases the risk, and we need to be even more aware and vigilant than we have ever been. So encouraging your staff to wear a mask when they go to the store, um, hand sanitizer all the time, or disinfect your steering wheel in your car when you come back from getting in your car from the store, your door handles, those types of things. Keep doing those things. They're working, but we can't stop now. So just kind of keep that in mind. And part of that is staying up to date with what's going on locally with COVID in your area. There's the CDC website that monitors those things. And there's also this is a really neat website, this naccho.org. This is local health departments in every state. So you would just access this website with this link and click on Michigan, and then it will bring up, and you'd have to scroll down just a little bit to get off the map, but it's going to give you a listing of every local health department in your state. So you would just go down to find your local health department, and there's your contact information for them. So throughout this time, if you're having struggles, or, one of the things that we've learned, one of our lessons that's learned, is that our local health department is part of our team, or should be. So if you're having questions or comments or concerns or any of those things, you need to really understand how helpful your health department can really be, and have them help be part of the solution, and instead of just part of identifying the problem. Communication is hugely important in an ongoing basis. I'm going to talk a little bit later about the hit that long-term care is taking during this crisis, and I'm going to we'll talk about that a little bit. But be sure that you're communicating your plan, not only the disaster plan of if you have COVID cases in your facility, but then on an ongoing basis, how are you going to continue to protect your staff, your residents, your families. Moving forward, once things start to open up again and you start to start taking visitors again, and what are your policies for what type of surveillance you're going to do when someone comes to visit the facility and they're stopped in the reception area and their temperature's taken and they're given a mask and gloves and asked to put them on, and you know, given basic information about infection control and the policies of the facility to try to keep the residents safe and the employees safe. So but communicating those changes to your staff. Some facilities are holding like open video town halls with their residents who want to participate, families, staff, community, that they can come on and share their plans and what's going to look maybe a little differently once the facilities start to open again. And so there's a lot of different ways that you can use technology to communicate that information to your residents, your staff, and your family. And then, as I mentioned, you know, screening patients and visitors for symptoms before they're actually given access past the main reception area. So COVID updates. CMS continues to update guidance regularly. This is a policy and memos to states and regions link that is on the CMS website. This is where all of the policy memos are going to be housed. So if you had a policy memo from before, that will be there. Any new ones will be there. And so I really encourage you to um, bookmark this on your browser and just keep checking back pretty frequently. Typically, they're going to be delivered to your facility, but it's always good to make sure that you haven't missed one. And then the interim final rule and the new COVID-19 reporting requirements. This is something that was released on May the 8th. The CMS published that interim final rule. It is still in comment period, but there are some things that are in effect as we speak. So the COVID-19 reporting requirements require facilities to submit data to the CDC and to residents, the representatives and families of the residents in the facilities. So, you know, you need to, it's all about transparency. To be honest with you, it blows my mind that we didn't do this like month one, because our nursing facilities were the ones that were being just absolutely eviscerated by this sneaky, ugly virus. And I know that a lot of the media focus and attention and adoration went to hospitals, and justly so, but they did not take into consideration that our nursing facilities were facing very similar situations, and without the help and the support and the adoration and the, you know, everybody thinks you're wonderful, you know, those things that kind of bolster your mood and how you feel, and it's nice to be appreciated. Well, you know, long-term care, I guess I should say we should be used to it, because so often that's the way of it. I've been in this for over 25 years and I know how it goes. But in something like this, you guys are the heroes, because you have not had the support that a lot of the other areas have had. So, but that's my little soapbox, sorry about that. But now you're needing to actually submit the data on COVID cases in your facility. And they've got some pretty interesting enforcement. Failure to report will result in enforcement action, which means civil money penalties, fines. They've also updated survey tools with the COVID-19 focus survey, the entrance conference worksheet, the COVID-19 survey protocol, and the summary of the COVID-19 focus survey for nursing homes to reflect COVID reporting requirements. So those items have been updated. And they've also added a couple F tags for COVID. And those are in related to reporting and just monitoring and COVID related. So as I said, this is all in an effort to bring transparency to long-term care facilities and get a better understanding of the prevalence of COVID in nursing homes. So let's talk about the expectations and the enforcement activity. Facilities will be provided with an initial 2-week grace period to begin reporting cases to the NHSM system, which ends at 11:59 on May 24th. Facilities that fail to begin reporting after that 3rd week, which is by May 31st, will receive a warning letter from the CDC. And then for facilities that have not started reporting to the NHSN system by June 7th, which ends the 4th week of the reporting requirement timeframe, CMS will impose a per day or PD civil monetary penalty or CMP of $1,000 for 1 day for the failure to report that week. Now let me clarify, and this is my interpretation based on their verbiage here. It's not that they're going to charge you $7,000 for 7 days of noncompliance for that week, but they're going to charge you the 1 day of $1,000 for failing to report that week. Okay, and we'll talk about that in an example because this is the way that they did this. Is a bit confusing to me, but and then for each subsequent week that the facility fails to submit the required report, they'll add an additional $500 to the amount that will be increased. So for example, if a facility fails to report in week 4 following that 2-week grace period and receipt of the warning letter, then they're going to be imposed a $1,000 1-day PDCMP for that week. If it fails to report again in week 5, the non-compliance would lead to the imposition of another 1-day PDCMP. And remember, because each week they're going to add $500 to that amount, now we're looking at that second week of non-compliance would be $1,500 for a total CMP of $2,500. So each week it's going to grow and grow and grow. So if you haven't had an opportunity yet to register and get signed up for that, the NHSN, which will allow you to enter your numbers into their system, I encourage you to do that as quickly as possible. You don't want to start getting nasty letters from CMS or the CDC, and you sure don't want to start having to pay fines. Okay. The return to work criteria. So if the HCP or the healthcare professional are tested and found to be infected with COVID, they should be excluded from work until they meet all return to work criteria. Now, there are some exceptions to this, and you can find in the return to work document where if you have exhausted all other employee staffing challenges, if you're really low staffed, there are conditions where they can go back to work while still being positive for COVID. But that is all lined out, and be sure that you take a look at that. It's like a big, huge caveat and different exclusions. So, but for the return to work criteria itself, if you're a symptomatic healthcare professional with suspected or confirmed COVID, there are two different strategies that you can take to determine whether or not that person is allowed to return to work. And the first one is a symptom-based strategy. And that is at least 3 days or 72 hours have passed since recovery, defined as the resolution of fever without the use of fever-reducing medication like Tylenol or whatever, and improvement in respiratory symptoms like your cough or your shortness of breath, and at least 10 days have passed since symptoms first appeared. So this tells you a few things. You need to be able to document on your employees the date that symptoms first appeared, and then you need to have, if you use like a spreadsheet or however it is that you document that, be sure that you have a place where, you know, that since there's been no fever for 72 hours, check. Their cough and their shortness of breath have resolved, or at least at baseline, check. And it's been 10 days since their symptoms first appeared, check. Now they're eligible to return to work. The next way to determine if someone's eligible to return to work is their test-based strategy. And this is, the first two are present in the symptom-based strategy, which is the resolution of fever without Tylenol or fever-reducing medications, and the improvement in their respiratory symptoms, their cough or shortness of breath, or it's back to baseline. And but the third criteria for this strategy is negative test result, twice. So you have at least 2 consecutive respiratory specimens collected within 24 hours or greater than each other, and they both have to be negative, and it has to be the specific COVID-19 test that's been approved by the FDA for emergency use, for being authorized for the COVID-19. So it's important that all 3 of these are addressed. And so on your spreadsheet, you could have the first 2 is going to be collected on everybody, because that's part of the criteria for both strategies. But then you would either have either one, the 10 days since the beginning of symptoms occurred, and or then you have your test-based strategy. So it could be one, or it would be one or the other of that third criteria. So all of this is included in detail on these 2 links that are available on this slide here. And then there's also healthcare providers with lab confirmed COVID who have not had any symptoms. Now, one of the things that has been proposed, and I suspect will be made, part of the strategy for opening nursing homes, is testing. Testing employees, testing residents, and then testing once a week everybody again. So this is going to be, a pretty huge undertaking. But what I suspect you will find is that there are going to be people in your facility who test positive for COVID, either staff or residents, who are completely asymptomatic. So what you won't know at that point in time is when they're asymptomatic, that makes this even sneakier, because when were they exposed? And are they just in that, 7-ish day period where someone who tests positive can be asymptomatic and they're going to exhibit symptoms soon? Or are they going to be part of the population that tests positive for COVID that never exhibits symptoms? So when you have someone who, oh my gosh, I feel fine. I don't have a fever or cough, anything. I'm not tired. I don't have any GI distress. I'm doing good. Haven't lost my sense of smell or taste. I'm fine. but I've just tested positive for COVID. So in those instances, the time-based strategy for determining who of those can return to work is 10 days have passed since the date of their first positive COVID diagnostic test, and then assuming that they don't develop symptoms in that 10-day period, then that would kind of begin the clock again for any of the other strategies to determine return to work. So you would use either the symptom-based or the test-based strategy after they start exhibiting symptoms. So, and like I said, because the symptoms can't be used to gauge where these individuals are in the course of that illness, it's possible that the duration of the viral shedding could be longer or shorter than 10 days after the first positive test. So even though those people come back to work, I sure would have them in a respirator when they're in contact with uninfected residents or other staff. And that's the other thing to keep in mind. Not only do we need to protect our residents, of course, but we also need to protect each other. So when they're in the break room, if they have to take their mask off, it's important that they do it where they're not near anyone else. Like to eat or drink, or they just need, you know, to breathe for a little while. They need to have a safe place to go do that away from everybody else. And then the test-based strategy is that they get a negative result from the test, at least 2 consecutive respiratory symptom or specimens collected greater or equal to 24 hours apart, totaling 2 negative specimens, then they can go back to work. But again, what they found is that it's not possible to gauge where they are in their individual course of illness. And also there have been reports of prolonged detection of RNA in the tests without a direct correlation to viral culture. So they may test positive for COVID, but if they do a sputum culture, it doesn't grow COVID. So, okay, the RNA is in their blood, but it's not in their sputum. So again, there's still so much that we're learning about COVID and you know, just its behavior as a virus, and so we're still so very early in this process. But this is the guidance that they've provided on when you can safely allow someone to come back to work. But remember, for these folks, after they return to work, wear a face mask for source control at all times, and not a cloth face covering. Remember, that's not PPE. And the universal source control, that was on a link to that was on the slide earlier. A face mask for source control does not replace the need to wear an N95 or higher level respirator when indicated. So if they're going to be working with COVID negative residents, you know, I would think they would need to have an N95 mask on. What some people do is they cohort all of their positive COVID residents in one area, and then the staff that are positive for COVID but feel well enough to work, that's who takes care of the COVID patients. So they're all cohorting staff and residents in the same area and protecting those who are non-COVID. You know, they basically have 2 separate and distinct groups and try not to have any cross-contamination between the 2. And then again, just remember that those N95 masks or other respirators with an exhaust valve might not provide source control. So, and that's so very important if you're one of those that's a tested positive. Okay, boy, I'm talking fast. All right, we're just about done here. One of the things that I want to talk about with you, and I think this is one of the biggest lessons that we've learned, as an industry, as a group of humans taking care of other humans, you cannot pour from an empty cup. And by that, I mean outbreaks are incredibly stressful. And I don't think I personally, in my professional career, have never experienced anything that has tested the mettle of healthcare providers like this has. Um, just the fear involved in it. Am I going to take it home to my family? Am I going to pick something up at home and bring it home to or bring it into my residence? I mean, there's so much unknown still, so much that we're still learning. But stress and compassion fatigue during a pandemic or something like this can include things like fear and worry about your own health and the health of your loved ones, sleep disturbance, insomnia, nightmares, difficulty concentrating or irritability, the loss of hope. I mean, when you think about the future, I mean, sometimes I feel like that. I'm like, oh my gosh, we're never going to get back to where we were. And we may, but right now it's hard to imagine that with just how much in the forefront this is. Mental and physical exhaustion, the loss of empathy, discouragement, and there's a lot of other things that each individual may face or experience that maybe other people don't. So I encourage you to look at this compassion fatigue article. It's very interesting, and it really brings to the forefront the importance of us not only taking care of ourselves and each other physically, but mentally and emotionally. I know there's always been such a stigma about mental health and, you know, getting burned out, and, you know, it's almost looked at as a sign of weakness, and nothing could be further from the truth. So when you're thinking about yourself, and I know y'all are going to probably either log off now or roll your eyes and go, oh boy, here we go. And let me share, I was in your boat, but I have learned how therapeutic and how helpful meditation can be, just closing your eyes and just quieting and controlling your breathing in and out. Um, the other thing that I encourage everyone to do is take a break from watching TV, reading or listening to news stories, which are not helpful to long-term care facilities. I mean, the press is just so negative about long-term care. They have no idea. And it's always easy to kind of pick on the long-term care facilities, but they have no idea the complexity of the care that we provide. So just turn it off. Don't listen to them. They don't know anyway. We're going to have to, as an industry, get together and do some serious marketing again. We've got to get our name back again. They make it sound like we're just letting people die and cross-contaminating everybody. They have no idea. We're not. As a matter of fact, I would challenge that long-term care is more efficient and more effective in being able to address these types of things that hospitals are. But that's just me. So try to let go of the negativity. Know in your heart that you know what is happening and you know that you're doing a good job, or as good a job as anybody could possibly do. Take care of your body, meditate. I love the Calm Act. I have a trouble with sleeping. And so there's different things on the Calm Act that can really help quiet my brain, because my brain has a bunch of squirrels in it sometimes, and they will not quiet at night. And so, and there's other apps, or you can just do your own guided meditation. You don't have to have an app for it, but try to eat healthy, well-balanced meals, exercise, get plenty of sleep, avoid drug and alcohol. Make time to unwind it. I know how we are. We're caregivers, right? And here's some more references there. Healthcare providers are caregivers. We're givers. We care about people. We put others' needs above our own. And what happens then is we run out of gas, right? So I don't know if it was a podcast I was listening to or an article or something, but they were talking about you need to understand who you are, and are you a Ferrari or are you a Prius? Now, there's nothing wrong with either one of those, but they serve very different functions. And so if you have 10 gallons of gas and you're a Ferrari, how far are you going to get? Well, not real far, right? If you're a Prius, I mean, you could go for days on 10 gallons of gas. So you need to understand who you are and understand your miles per gallon, right? And don't forget to refuel. If you continue to just care for others and never refuel, never fill your own cup, then you are going to get compassion fatigue. You're going to get mentally and physically ill. Your body will at some point demand that you stop. So if, I used to travel a lot before COVID, and when they're going through the safety for the airplane, and they'll say, if you're traveling with someone who might need assistance, put your mask on first. And the theory behind that is, if you're 30,000 feet and there's no oxygen, if you try to put somebody else's mask on first, you could pass out and then you're not going to help anybody, right? So you put your own mask on first and then you help someone else. And that really applies to our day-to-day life. We have to put our mask on first in order to be able to help others. And just remember, you cannot pour from an empty cup. So here are some resources for disaster distress helpline, suicide helplines, national domestic violence. Boy, this is something that really has become very prevalent, sadly. And it's not just in the United States, but with all of the countries that have been on lockdown, domestic violence has just skyrocketed. So if you or someone you love are struggling with any of these things, please seek help. We need you. You're valuable to us and we want you to be okay. And there is help. So the other thing is, be sure you share this with your staff, right? So you're on this call, you care about your residents and you want to make sure you've got the latest information to take care of everybody. Don't forget your staff, please. They're going through these things and they need these support services as well. So that's really going to be, I think, our new normal moving forward, is not only dealing with the physical of ourselves and of our residents, but also dealing with the emotional and the mental and the psychological health of ourselves and our residents. So some of the things, some of the lessons learned: how do we open to the public again? During times of social distancing, how do we fill the emotional gap with our residents? And you've been doing this beautifully. And I know that from my own personal experience. How do we control entrance into our facility once we open? How do we communicate effectively to the staff, residents, families, and the public? Do town halls. Open it to the public. Talk to your local radio station. You can get on there and they can interview you about anything you want to be interviewed about, and get on, local radio. Do you have a recovery or reputation marketing plan? And as I mentioned, ACA is going to, I'm sure, provide wonderful resources to facilities, American Healthcare Association, but be prepared for that, to just have to try to undo a lot of the bad press that we've gotten. Know where COVID is in your area. Do you have mental health resources available to your staff, your residents, and families? Do we have a mechanism in place for staff to share their challenges in the face of COVID-19? Do you have a happy hour where you serve, chips and dip and sodas, and you all sit down and just talk to each other? Share experiences, share your fears, share what you're doing, how you're making it work. Just share, communicate with each other. That in and of itself can be so, so very helpful. And do you have plans in place for ongoing staffing issues? And that's a whole nother thing, but staffing, it's always the bane of our existence, right? But in a pandemic, it can even be more challenging. I did add some resources to the end of the slide deck just for your use. And now we'll go ahead and open it up to questions.
All right. Thank you very much for that, Pam. Let me go ahead and open up the questions tab here really fast. All right, I am not seeing any questions so far. So, in case anybody is thinking of
Okay,
something right now or typing
great.
anything right now, I did just want to say thank you again to Pam for being the presenter with us today, and to PointClickCare for generously supporting our Save and Calm series and being a great business partner to us. We would also like to thank all the members. I believe we topped out at around 30 today that took their time out of their busy schedules to join us for today's webinar. We appreciate everything you do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Just a quick reminder that we do have another COVID-19 webinar with Deanna Mitchell tomorrow morning at 11 a.m. Eastern Standard Time, and you should, if you're already registered for that, receive a reminder email 1 hour before that, so you'll receive that at 10 a.m. We also have a Housing Matters program scheduled for next week, May 28th, so it will be next Thursday. If you're interested in that, you can go ahead and register on leadingagemi.org. If you have any questions about any of this stuff, you can go ahead and email me. It's Blake, B-L-A-K-E, at leadingagemi.org, or you can email info@leadingagemi.org, and we can make sure that we get those registration links over to you or anything else that you may need. I am not seeing any questions come through. So again, thank you very much to PointClickCare, and thank you very much to Pam. If you have anything else to say,
It's
Pam.
been my pleasure. I would just like to tell you all, thank you so much for everything you do. You are heroes, and I couldn't be more proud of our industry. I know we've been challenged, but as always, we rise to that occasion. So thank you all for what you do. You're awesome. Thank you.
All right, thank you very much, and everyone have a great day.